Welcome to the deep dive. We're skipping the fluff today and getting straight into the high-yield, must-know details you need.
That's right. If you're grappling with pathophysiology, specifically respiratory, renal, GI, and endocrine systems, and you really need to lock down those critical mechanisms for your exams, well, this is for you.
Yeah, our mission is super focused. We're basically creating a verbal study guide right here, right now. We'll hit the core definitions, the step-by-step processes, and those essential comparisons that, let's face it, are almost guaranteed to show up on tests, especially those tricky mechanism questions.
Exactly. We'll go system by system, aiming for clarity and rapid recall. So, no time to waste. Let's jump right into respiratory function, starting with Chapter 29 material.
Okay, respiratory system basics. The conducting airways, nose, pharynx, larynx, trachea, bronchi, obviously, they move air. But what's that vital secondary function we need to remember?
It's all about conditioning the air. Think preparation. Before that air hits the delicate alveoli, it needs to be warmed, filtered, and humidified. And that happens largely thanks to the rich blood supply in the airway walls and, crucially, the mucociliary blanket.
Ah, yes, the mucociliary blanket. That's like the first line of defense, isn't it? This layer of mucus.
It's sitting right on top of those ciliated epithelial cells.
And it's constantly trapping dust, pollen, bacteria, you name it. So how does it actually get that trapped stuff out?
It's a really neat system, actually. Think of it like a microscopic escalator.
An escalator, okay.
Yeah, these tiny cilia, they beat together in this coordinated wave, constantly moving that whole mucus blanket upwards.
That's towards the throat.
Exactly, toward the oropharynx. And once it gets there, it's either swallowed, usually unconsciously, or coughed out.
Makes sense. But for clinical purposes, what stops this escalator? What compromises the system? That seems critical.
Absolutely critical. There are three main factors you absolutely have to know.
Okay, what are they?
First, low oxygen levels or low oxygen tension. Second, drying conditions like breathing really dry, heated air that hasn't been humidified.
Right, like in winter sometimes.
Exactly. And the third, the big one, is cigarette smoking.
Of course. How does smoking affect it?
Smoking directly slows down the cilia. It can even paralyze them completely.
Wow, paralyze them.
Yeah. And if that transport system stops working, all those trapped toxins and particles just sit there. They don't get cleared.
Leading to irritation, inflammation, infection risk.
Precisely.
Yeah.
It's a direct pathway to chronic respiratory problems.
Okay, moving up slightly, let's quickly define the parts of the larynx, the voice box. We have the vestibular folds.
Those are mainly for protection. Think of them as sort of guardian folds.
And then the vocal folds.
Those are the ones that vibrate to actually produce sound.
And the space between the vocal folds?
That's the glottis. So the glottis is technically the vocal folds plus that opening between them.
Got it. And the structure that prevents food from going down the wrong pipe?
That would be the epiglottis. It's this leaf-shaped piece of cartilage.
Right.
When you swallow, it automatically flips downwards, covering the opening of the larynx.
So it routes food and liquids safely into the esophagus, away from the trachea.
Exactly. A crucial protective reflex. It has to work perfectly every time to prevent aspiration. #2. Alveolar gas exchange and surfactant.
All right, now let's get to the business end, the alveoli, where gas exchange actually happens. For this to work efficiently, we need three things happening correctly and, importantly, in sync.
You need ventilation, which is just the mechanics air flowing into and out of the alveoli.
Okay.
Then you need perfusion. That's the blood flow through the pulmonary capillaries right next to the alveoli.
Yeah, makes sense. Air meets blood.
And finally, diffusion. That's the actual movement of gases, oxygen, and CO2 across that very thin alveolar capillary membrane. And the key is matching ventilation and perfusion. You need good airflow and good blood flow in the same place at the same time.
Right. VQ matching.
Exactly. And none of that diffusion works properly without surfactant.
Produced by those type 2 alveolar cells, right?
Correct. It's this complex mix of phospholipids and proteins. And its main job, its primary function, is to reduce surface tension.
Okay. Why is lowering surface tension so vital in the lungs?
Well, think about water molecules. They naturally want to stick together, right? That's surface tension. Inside those tiny, moist alveoli, that force would be immense. Without something to counteract it, the alveoli would just collapse in on themselves, especially when you breathe out.
Ah, so surfactant breaks that tension.
Precisely. It gets between the water molecules at that air-liquid interface, reducing the tension. This makes the lungs much easier to inflate it, increases lung compliance.
Compliance meaning the stretchiness or ease of inflation?
Exactly. makes the work of breathing much less effortful.
Now, the surfactant proteins themselves, SPA, B, C, D, I know this comes up. 2 are mainly for the mechanics, 2 for defense.
That's the key distinction, yes.
Yeah.
SPB and SPC are the workhorses for reducing surface tension.
Okay, B and C.
SPB is absolutely critical for actually forming that surface film that lowers the tension. SPC helps stabilize that film and prevents the alveoli from collapsing completely at the end of expiration.
And A and D?
SPA and SPD belong to the colectin family. Their role is innate immunity, host defense.
How do they do that?
They act like opsonins. They basically tag pathogens, bacteria, viruses, making them easier for phagocytes like macrophages to recognize and engulf.
Like putting a kick me sign on the bacteria?
Kind of, yeah. And they also have some direct bactericidal activity themselves, so they're part of the lung's built-in defense system. Hashtag tag 3, mechanics of breathing and lung volumes.
Okay, let's talk mechanics. Breathing fundamentally relies on changing the chest volume to create a pressure difference, right? Air flows from high to low pressure.
Correct. Inspiration expands the chest, lowering pressure inside, air flows in. Expiration involves elastic recoil, increasing pressure, air flows out. But airflow isn't always easy. There's a resistance.
Airway resistance. And there's a really important relationship governing this, involving the radius of the airway.
Yes, and this is crucial to grasp. Resistance is inversely related to the fourth power of the airway radius.
Fourth power. So not just inversely related, but dramatically so.
Exactly. Let me put it this way. If inflammation or mucus cuts the radius of a bronchus in half, the resistance to airflow doesn't just double. It increases by 2 times, 2 times, 2 times, 16 times.
16 times. Wow. That explains why even a little bit of swelling in asthma or COPD can make breathing so incredibly difficult.
Absolutely. It highlights the physics behind the pathology. And the force working against that resistance is compliance, the ease of inflation we talked about.
Determined by elastic fibers, water content, and, as we said, surfactant.
And we measure these mechanics with spirometry, looking at lung volumes. The most basic is tidal volume, VT.
That's just the amount of air in a normal, quiet breath in and out.
Yep, typically around 500 millimole in an average adult.
Then we have the reserves you can call upon.
Right. Inspiratory reserve volume, IRV, is the extra amount you can breathe in deeply beyond your normal tidal volume.
And expiratory reserve volume, ERV.
That's the maximum amount you can forcefully breathe out after a normal exhalation.
But there's air left even after you force everything out, right?
Yes, and that's the residual volume, RV. It's about 1,200 milliliter or so, the air that always stays in the lungs to keep the alveoli open.
And does RV change?
It does. It tends to increase naturally with age, partly due to some loss of elastic recoil, but it increases significantly in obstructive diseases like emphysema because air gets trapped and can't be exhaled.
Okay, now for the test involving forced breathing. FVC, forced vital capacity.
That's the total amount of air you can forcefully exhale after taking the deepest possible breath in.
And the really key measurement often compared to FVC is?
FEV 1.0.
Yeah.
That's the volume of air expired in the first second of that forced exhalation. The ratio of FEV1 to FVC is a critical indicator of obstruction.
And what does it mean if the FVC measurement itself is lower when done forcefully compared to when done slowly, slow vital capacity?
That's a classic sign of obstruction and air trapping.
Why does that happen?
Because in obstructive diseases, the airways tend to be floppy and lack support. The forceful effort of exhaling actually increases the pressure around these weak airways, causing them to collapse prematurely.
So they slam shut before all the air can get out.
Exactly. It traps air behind the collapse segment, reducing the total volume exhaled during the forced maneuver compared to a slow, gentle exhalation where pressures don't build up as much. Hashtag PEG4, gas transport and control.
All right, we've covered the structure and mechanics. Now moving the actual gases, oxygen transport, it's almost all bound to hemoglobin, right?
Overwhelmingly so. About 98 to 99% of oxygen is transported bound to the iron in hemoglobin, HB.
But that bound oxygen isn't what actually crosses into the tissues.
No, that's the crucial point. It's the tiny fraction, only 1 to 2%, that's physically dissolved in the plasma.
Okay.
Only dissolved oxygen can diffuse across cell membranes. And it's the concentration of this dissolved O2 that determines the partial pressure of oxygen, the PO2.
So the PO2 we measure reflects the dissolved portion, which drives diffusion.
Precisely. Hemoglobin acts as the reservoir, releasing O2 to keep that dissolved pool replenished as tissues consume it.
And hemoglobin's grip on oxygen isn't constant. It changes based on the local environment, which is pretty clever.
It's beautifully adapted. Hemoglobin's affinity for oxygen, how tightly it holds on, changes.
So when does it let go more easily, where the tissues need it most?
Exactly. Affinity decreases, meaning it releases O2 more readily when the environment becomes more acidic, lower pH, when CO2 levels increase, or when the temperature goes up, like in actively metabolizing tissues, or during a fever.
Makes sense. Deliver the goods where the action is.
Right. And conversely, affinity increases. HB holds onto O2 tighter in alkalosis, higher pH, with lower CO2 levels, or in colder temperatures, like in the lungs, where you want it to load up efficiently.
That relationship is the Bohr effect, right?
That's the Bohr effect, yes. Essential physiology.
Now, carbon dioxide transport is a bit more complex, 3 ways.
3 main ways, yes. A small amount is dissolved in plasma, just like oxygen. Some binds directly to hemoglobin, but not at the oxygen binding site forming carbaminohemoglobin. It's a loose, reversible bond. But the vast majority, the most significant portion, is transported after being converted into bicarbonate ions, HCO3, within the red blood cells through the action of carbonic anhydrase.
Right, the bicarbonate buffer system.
Exactly. And there's a fascinating interaction here, too, called the Haldane effect.
What's that?
Basically, when hemoglobin releases oxygen in the tissues, its structure changes slightly. And this change actually increases its ability to bind CO2, both directly as carbaminohemoglobin and by facilitating bicarbonate formation.
So dropping off oxygen helps pick up CO2.
Yes, and the reverse happens in the lungs. Picking up oxygen helps unload CO2. It makes the whole gas exchange process incredibly efficient.
Clever design. Now, who's in charge? What controls how fast and deep we breathe? The chemoreceptors.
We have 2 main sets. The central chemoreceptors are located right in the medulla of the brainstem.
And they're the main drivers for everyday breathing.
Yes. They are the most important for regulating ventilation moment to moment under normal conditions. They're extremely sensitive to changes in the PCO2 in the blood.
But they don't sense CO2 directly, do they?
Correct. They actually sense the changes in hydrogen ion concentration, H+, the acidity in the cerebrospinal fluid, CSF, that result from changes in blood PCO2. CO2 diffuses easily into the CSF, forms carbonic acid, releases H+ POC, and that H+ stimulates the receptors.
So higher CO2 means higher H+ in the CSF, signaling acidosis, which triggers increased breathing to blow off CO2.
You got it. That's the primary feedback loop.
Then we have the peripheral chemoreceptors. Where are they?
They're located in the carotid bodies at the bifurcation of the common carotid arteries and the aortic bodies in the aortic arch.
And what do they monitor?
They also monitor PCO2 and pH, but their really unique and critical role is monitoring the PO2, the oxygen levels, in the arterial blood.
But they're not very sensitive to small drops in oxygen, are they?
No, surprisingly sluggish in that regard. They don't significantly stimulate ventilation until the arterial PO2 drops quite low, generally below about 60 millimeter Hg.
And this is where that crucial clinical point comes in, especially with COPD patients.
Absolutely. This is a classic high-stakes scenario. A patient with severe COPD often has chronically high CO2 levels, hypercapnia. Over time, their central chemoreceptors become desensitized to that high CO2. It's like the alarm system gets tired of ringing.
So the main thing keeping them breathing adequately is low oxygen.
Exactly. For these patients, hypoxia, that PO2 dropping below 60 millimeter Hg, becomes the primary stimulus driving their ventilation, mediated entirely by those peripheral chemoreceptors.
So if you give them too much supplemental oxygen,
You raise their PO2 above that 60 millimeter Hg threshold, you effectively switch off their only remaining drive to breathe.
which can lead to hypoventilation, further CO2 retention, and even respiratory arrest.
A potentially fatal mistake.
Yeah.
It underscores why oxygen is a drug and needs to be administered cautiously and judiciously in this population. You're walking a fine line.
That's a perfect foundation. Let's transition now to what happens when things go wrong respiratory pathology. We'll start with infections. Before we move on, let's solidify this. A good exam question might be, describe the mucociliary blanket, its components, function, and list 3 key factors that impair it.
Good one. You need to mention the mucus layer, the ciliated cells, the escalator function, and then hit low O2, drying, and smoking as impairing factors.
Or maybe a clinical application. A patient with severe COPD and chronic hypercapnia has a PO2 of 55 millimeter Hg. Which chemoreceptors are primarily driving ventilation and why?
That tests the hypoxic drive concept. The answer is the peripheral chemoreceptors, because the central ones are desensitized to CO2, and PO2 is below 60.
How about surfactant? Which two surfactant proteins are most important for reducing surface tension and increasing compliance?
That would be SPB and SPC. Got to know those two specifically for the mechanics.
And finally, maybe an interpretation question. If a patient's forced vital capacity, FVC, is significantly lower than their slow vital capacity, SVC, what does that suggest?
That suggests airway collapse during forced expiration, characteristic of obstructive lung disease. It implies air trapping. Okay, ready for pathology.
Let's do it. Chapter 30 and 31. Okay, common stuff first. The common cold versus a bacterial sinus infection. How do you generally tell the difference based on timing?
Well, acute viral rhinosinusitis. The common cold usually gets better on its own within about 5 to 7 days. Symptoms peak and then resolve.
And bacterial.
Acute bacterial rhinosinusitis is more likely if the symptoms actually get worse after that initial 5-7 day period, or if they just hang around, persisting for more than 10 days without improving.
So worsening or just not getting better after that typical viral time frame.
Exactly. And while treatments like mucolytics, decongestants, maybe nasal steroids, and sometimes antibiotics are used, it's interesting, about 2/3 of bacterial cases probably resolve without antibiotics anyway.
Good point. Okay, influenza the flu, types A, B, C. Type A is the one with the subtypes, right? Based on surface proteins.
Correct. Type A subtypes are based on hemagglutinin, or HA, and neuraminidase, or NA.
What do HA and NA do?
HA is the key. It allows the virus to attach to and enter the host cell. NA is involved later. It helps new virus particles replicate and get released from the cell to infect others.
Got it. And a really critical, though rare, complication associated with flu, especially in kids.
Ray's syndrome. You must remember this connection.
What is it and why the connection?
It's a severe illness causing fatty liver changes and acute encephalopathy, brain swelling. It's strongly linked to giving aspirin or salicylate-containing products to children or teenagers who have influenza or chickenpox.
So absolutely no aspirin for fever in kids with flu-like symptoms.
Never. Acetaminophen or ibuprofen are the alternatives. #2, pneumonias and TB. Key classifications and stages.
Moving on to pneumonia. First, just the anatomical pattern. Lobar versus bronchop pneumonia.
Simple distinction. Lobar pneumonia means a whole section or even an entire lobe of the lung is consolidated, filled with exudate.
Solidified, basically.
Yeah, whereas bronchop pneumonia is patchier. You see scattered, small areas of consolidation, often involving more than one lobe.
Okay. Now, the classic stages of pneumococcal pneumonia are caused by Streptococcus pneumonia. This sequence is vital to memorize. What's stage 1?
Stage 1 is edema, or congestion. The alveoli start filling up with this protein-rich edema fluid, and you find lots of bacteria multiplying in there. It's boggy. Red hepatization. This is the dramatic stage. There's a massive influx of red blood cells, neutrophils, polymorphonuclear leukocytes, and fibrin into the alveoli. The lung tissue becomes firm, dense, and reddish, resembling the consistency of liver, hence hepatization.
So red liver lung. That's the key image for stage 2, stage 3.
Gray hepatization. The red cells start to break down, but neutrophils and fibrin persist. Macrophages start arriving in large numbers to clean things up. The lung is still firm, but the color fades to grayish-brown.
And finally, stage 4.
Resolution. The macrophages digest the remaining debris, the exudate gets cleared by coughing or lymphatic drainage, and hopefully the lung structure returns to normal. Edema, red, gray, resolution.
Got it. Okay, tuberculosis, PB, the skin test, the TST or PPD. What does a positive result actually mean?
This is a huge point of potential confusion. A positive TST indicates that the person's immune system has been exposed to the Mycobacterium tuberculosis bacillus at some point and has developed a cell-mediated type A hypersensitivity reaction to its proteins.
So exposure and immune response, but not necessarily active disease.
Exactly. It does not tell you if the person has active infectious TB right now. It just means they've encountered it before. Further tests like chest x-ray and sputum analysis are needed to diagnose active disease.
And what's a major pitfall with interpreting the TST? When might it be falsely negative?
Anergy. This is critical.
Anergy, meaning lack of reaction.
Yes. If a person is significantly immunocompromised, maybe due to HIV infection, immunosuppressive drugs like high-dose steroids, certain cancers, or even advanced age or severe malnutrition, their immune system might be too weak to mount any reaction, even if they are infected with TB.
So someone could have TB, but their skin test is negative because their immune system can't respond.
Precisely. You cannot rely on a negative TST to rule out TB in an immunocompromised individual. Take 3. Childhood respiratory distress syndrome, RDS.
Okay, let's shift to newborns. Respiratory distress syndrome, or RDS. This is primarily a disease of prematurity, right? What's the core problem?
The core problem is a deficiency of pulmonary surfactant.
Because the lungs aren't mature enough to make it.
Exactly. Those type 2 alveolar cells, the ones that produce surfactant, typically don't fully mature and start producing adequate amounts until around the 25th to 28th week of gestation, sometimes even later.
So a baby born before that just doesn't have enough surfactant. What happens then?
Without enough surfactant to lower that surface tension, the alveoli tend to collapse at the end of each breath. This widespread collapse is called atelectasis.
Making it incredibly hard work to reinflate them with every breath.
Immense work. It leads to severe hypoxemia, low oxygen, and hypercapnia, retained CO2. On top of that, damaged alveolar cells and plasma proteins leak into the alveoli, forming this thick, glassy membrane called a hyaline membrane.
Which further blocks gas exchange.
Correct. It's a vicious cycle. Surfactant deficiency, atelectasis, hypoxemia, hypercapnia, hyaline membrane formation, worsening gas exchange.
Besides prematurity itself, are there other specific risk factors that increase the chance of RDS?
Yes, a couple of important ones. Infants born to mothers with diabetes, particularly insulin-dependent diabetes, are at higher risk.
Why is that?
High levels of insulin in the fetus actually seem to inhibit surfactant production by those type 2 cells.
Interesting. What else?
Delivered by cesarean section, especially if it's done before labor begins.
How does C-section affect it?
The stress of normal labor and delivery triggers a surge of cortisol in the baby. Cortisol actually helps accelerate the maturation of those type 2 alveolar cells and surfactant production. Without that labor stress, maturation might be slightly delayed.
Okay, so prematurity, maternal diabetes, C-section without labor. What are the classic signs you'd see in a newborn with RDS? What does respiratory distress look like?
You'd see central cyanosis of bluish tinge around the lips and mucous membranes. You'd see retractions, the soft chest wall gets sucked inward between the ribs or under the sternum during inspiration because the baby is generating such high negative pressure to try and inflate the stiff lungs.
What else?
Tachypnea, a very rapid respiratory rate, often 60 to 120 breaths per minute, which is much faster than normal. And you often hear an expiratory grunt.
Grunting.
Yeah, it's a sound they make as they exhale against a partially closed glottis. It's thought to be an attempt to maintain some positive pressure in the airways and prevent further alveolar collapse. Cyanosis, retractions, tachypnea, grunting, those are the hallmarks. Hashtag the 4. Obstructive airway disorders.
All right, let's tackle the major obstructive disorders where the primary problem is difficulty getting air out. Asthma first. It's fundamentally about chronic inflammation, right?
Chronic inflammation is the absolute bedrock of asthma. This inflammation leads to episodic airway obstruction, bronchial hyperresponsiveness, the airways are twitchy and react easily to triggers, and that underlying inflammation.
And which immune cells and mediators are the main players in that inflammation?
It's often a T helper 2, T2H cell-driven process.
Yep.
These cells orchestrate the response involving IgE antibodies, eosinophils, and mast cells.
Mast cells releasing histamine and
Leukotrienes, which are potent bronchoconstrictors and pro-inflammatory mediators. Eosinophils also contribute significantly to the inflammation and tissue damage.
And if this inflammation goes on unchecked for a long time?
That's where you get airway remodeling. The chronic inflammation can lead to permanent structural changes in the airways, thickened basement membrane, smooth muscle hypertrophy, mucus gland hyperplasia. These changes can make the obstruction irreversible over time.
Okay, a specific type. Aspirin or NSAID-induced asthma. Some people have severe reactions. What's the mechanism there?
It relates to prostaglandin synthesis. Aspirin and NSAIDs work by inhibiting the COX enzymes, cyclooxygenase.
Right.
Normally, COX enzymes help produce various prostaglandins, some of which are protective and help maintain bronchodilation. By blocking COX, particularly COX-1, these drugs shut down that protective pathway.
And shifts production towards?
It shunts the precursor molecules down another pathway, the lipoxygenase pathway, leading to an overproduction of leukotrienes.
Ah, those potent bronchoconstrictors we just mentioned.
Exactly. So in susceptible individuals, taking aspirin or an NSAID triggers a flood of leukotrienes, causing severe bronchospasm and asthma symptoms. Avoidance is the only management strategy.
Okay, moving to COPD, chronic obstructive pulmonary disease. This usually covers two conditions.
Primarily, yes, emphysema and chronic bronchitis, though many patients have features of both.
Let's define emphysema first. What's the core pathology?
Emphysema is defined by anatomical changes. It's the permanent, abnormal enlargement of the air spaces distal to the terminal bronchioles, so the respiratory bronchioles and alveoli. And this enlargement is accompanied by the destruction of their walls and, importantly, loss of elastic recoil.
So the structure breaks down and the springiness is gone. What's the main functional result?
Air trapping. Without the elastic recoil to help push air out, and with the airways potentially collapsing due to lost support, air gets trapped in those enlarged spaces during expiration. This leads to lung hyperinflation and an increased total lung capacity, TLC, and residual volume, RV.
Okay. Now, chronic bronchitis. This one's defined differently.
Yes, chronic bronchitis is a clinical diagnosis. It's defined as having a chronic productive cough, meaning coughing up sputum for at least 3 months of the year, for at least 2 consecutive years.
So based on symptoms over time, what's happening pathologically?
The pathology involves inflammation and swelling of the bronchial walls, hyperplasia, and hypertrophy of the submucosal glands, leading to excessive mucus production and obstruction of the smaller airways. It's primarily an airway problem, whereas emphysema is more about alveolar destruction.
Got it. Finally, in this group, cystic fibrosis. This is genetic, right?
Yes, CF is an autosomal recessive disorder. It's caused by mutations in the CFTR gene.
CFTR, what does that gene normally do?
The CFTR gene provides instructions for making a protein that functions as a channel across the membrane of epithelial cells, primarily transporting chloride ions.
So in CF, that chloride channel is defective. What's the consequence?
The dysfunctional CFTR protein disrupts the normal balance of salt and water transport across epithelial surfaces. The main result, especially in the airways and pancreas, is the production of abnormally thick, sticky, viscous mucus.
And that thick mucus causes problems by blocking things up.
Exactly. It obstructs the airways, leading to chronic lung infections, inflammation, and progressive lung damage. It also blocks the pancreatic duct,
Preventing digestive enzymes from reaching the intestine.
Right. This causes pancreatic exocrine insufficiency, leading to malabsorption of nutrients, especially fats, malnutrition, greasy stools, steatorrhea, and poor growth.
So the classic manifestations stem from this thick mucus.
Chronic respiratory disease, pancreatic insufficiency, and another hallmark is elevated salt, sodium chloride, levels in sweat, which forms the basis of the sweat test for diagnosis.
Okay, that covers the obstructive disease as well. Let's pause for potential questions on this section before hitting the kidneys.
All right, thinking about exam questions for this section, you absolutely need to know the 4 stages of pneumococcal pneumonia. A question might ask you to list them in order and identify the key characteristic of red hepatization.
Good one. Edema, red hepatization, RBCS, WBCs, liver-like, gray hepatization, macrophages arrive, resolution.
Definitely. Or they might ask you to differentiate Crohn's and ulcerative colitis based on key features like location, layer involvement, lesion pattern. Even though we'll cover that again in GI, it's often compared.
True, IBD comparison is classic. How about RDS, a mechanism question? Explain why infants born to mothers with insulin-dependent diabetes have an increased risk for RDS.
That hits the insulin-inhibiting surfactant production point. That's a good high-yield link.
And back to that critical clinical point, why must you be cautious giving high-flow oxygen to a COPD patient with chronic hypercapnia?
Test the understanding of the hypoxic drive versus the blunted central response. You need to explain why hypoxia is their main stimulus and what happens if you remove it. Okay, ready for the kidneys.
Let's dive into renal and urinary patho, chapters 33, 34, 35.
Okay, acute kidney injury, or AKI. The hallmark is a sudden decline in kidney function. You see rising nitrogenous wastes in the blood, that's azotemia, measured by BUN and creatinine, and a drop in the glomerular filtration rate, GFR.
And the key thing is, it's potentially reversible if you catch and treat the underlying cause.
Exactly. And we classify AKI based on where the problem originates: prerenal, intrarenal, or postrenal.
Let's start with prerenal AKI. This is the most common type, right? What's the fundamental issue?
The issue is before the kidney. It's caused by a marked decrease in renal blood flow, poor perfusion. The kidney itself is initially okay, it's just not getting enough blood.
What kind of things cause that?
Think severe volume depletion, like dehydration or hemorrhage, heart failure, cardiogenic shock where the pump fails, sepsis, where vasodilation drops pressure, anything that drastically reduces blood flow to the kidneys. Okay, how does the kidney respond? How do we diagnose it based on labs? The kidney, sensing low flow, goes into maximum conservation mode. It tries desperately to hold on to salt and water.
So urine output drops sharply. Oliguria.
Yes, oliguria is common. And the labs reflect this desperate conservation. 2 key indicators.
First,
The VUN to creatinine ratio. It gets disproportionately high, often greater than 15.1 or even 20.1.
Why does the ratio get skewed like that?
Because both BUN and creatinine are filtered at the glomerulus. But in the tubules, creatinine is mostly just secreted, while urea, BUN, gets passively reabsorbed along with water. When flow through the tubules is very slow, due to low GFR from poor perfusion, there's more time for urea to be reabsorbed back into the blood while creatinine stays in the tubule. So BUN climbs higher relative to creatinine.
Ah, the slow flow allows more BUN reabsorption. Got it. What's the second indicator?
The fractional excretion of sodium, FeNA. This measures how much of the sodium filtered by the glomeruli actually ends up being excreted in the urine.
And in pre-renal failure?
The tubules are working overtime to reabsorb sodium, and water follows. So very little sodium makes it into the final urine. The FeNA is typically very low, usually less than 1%.
So high BUN-CR ratio and low FeNA strongly suggest pre-renal AKI.
The problem is poor perfusion, but the tubules are still working.
Exactly. It tells you the kidney is responding appropriately to the low flow state.
Now contrast that with intrarenal AKI.
Here, the damage is within the kidney structures themselves. The most common cause of intrarenal AKI is acute tubular necrosis, or ATN.
Damage to the tubules themselves. What causes ATN?
Two main culprits. Prolonged ischemia, so severe prerenal failure that doesn't get corrected, can progress to ischemic ATN, or exposure to nephrotoxin substances directly poisonous to the tubule cells.
Can you give examples of common nephrotoxins? Sure. Certain antibiotics, especially aminoglycosides like gentamicin, some chemotherapy drugs like cisplatin, and radiocontrast dye used for imaging studies.
Why are the kidneys so vulnerable to toxins?
Couple of reasons. They receive a huge portion of cardiac output, about 20–25%, so they get exposed to high concentrations of anything in the blood. Plus, their job involves concentrating the filtrate, which can unfortunately also concentrate these toxins within the tubules, especially in the medulla.
And if the tubules are damaged in ATN, how does that affect the labs, like FeNA?
If the tubules are necrotic, they can't reabsorb sodium effectively, even if the body wants them to. So sodium gets wasted into the urine. In ATN, the FeNA is typically high, often greater than 2%. That's a key differentiator from prerenal.
Okay. Prerenal, low FeNA, 1%. Intrarenal, ATN. High FeNA, 2%. Makes sense. And the last type?
Postrenal AKI. This one's conceptually simpler. It's caused by an obstruction to urine outflow after the kidneys. Something is blocking the pipes downstream.
Like what?
Could be kidney stones blocking both ureters, or the single ureter of a solitary kidney, and a large prostate gland clamping down on the urethra, bladder outlet obstruction, tumors compressing the ureters, etc. Basically anything preventing urine from leaving the body. #tag2, chronic kidney disease, CKD manifestations, CHA34.
Okay, let's shift from acute injury to chronic kidney disease, CKD. This is defined as kidney damage or a GFR below 60 ln 1.73 mL2 lasting for 3 months or more. Kidney failure is defined as GFR below 15.
Right. And unlike AKI, CKD is generally progressive and irreversible. As function declines, the systemic consequences become widespread and severe. One of the most critical is CKD mineral and bone disorder, or CKD-MBD.
This is a complex cascade, right? It's essential to understand the steps in order. Where does it start?
It starts with impaired phosphate excretion. As GFR falls, the kidneys can't get rid of phosphate efficiently. So phosphate levels in the blood start to rise, hyperphosphatemia. That's step one.
Okay, high phosphate. What's next?
Phosphate and calcium have an inverse relationship in the serum. High phosphate levels tend to bind with calcium, causing serum calcium levels to drop, hypocalcemia. That's step two.
So step 3 involves vitamin D, doesn't it?
Yes, and this is often missed. The kidneys play a vital role in activating vitamin D into its usable form, calcitriol. Failing kidneys can't do this activation step properly.
And why does active vitamin D matter for calcium?
Active vitamin D is necessary for absorbing calcium from the gut. So without it, you get decreased calcium absorption, which makes the hypocalcemia even worse. Step 3 is impaired vitamin D activation, compounding the hypocalcemia.
So we have high phosphate, low calcium, made worse by low active D. What's the final step?
The body senses the dangerously low calcium. The parathyroid glands go into overdrive, pumping out parathyroid hormone, PTH, relentlessly. This is secondary hyperparathyroidism.
And what does all that excess PTH do?
PTH tries to raise serum calcium by stimulating osteoclasts to break down bone, releasing calcium and more phosphate into the blood. While this might temporarily help serum calcium, the long-term effect is devastating to the skeleton.
Leading to bone pain, increased fracture risk.
Exactly. That whole process results in renal osteodystrophy, the bone disease characteristic of CKD. High phosphate, that's low calcium, low active D, IPTH, bone breakdown. You have to know that sequence.
Absolutely critical cascade. Another major issue in CKD is anemia. Why does that happen?
Primarily because the failing kidneys stop producing enough erythropoietin, EPO.
EPO is the hormone that stimulates red blood cell production in the bone marrow.
Correct. EPO is mainly produced by specialized cells, peritubular fibroblasts, in the kidney. As kidney tissue is destroyed, EPO production plummets, leading to anemia of CKD.
And what's a physiological consequence of that chronic anemia?
Well, anemia means fewer red blood cells, which actually decreases the viscosity or thickness of the blood.
No.
To compensate and maintain oxygen delivery, the heart has to work harder. It increases heart rate and stroke volume, leading to increased cardiac output. Over time, this places a chronic strain, a volume overload on the heart.
So kidney failure leads to heart strain partly via anemia. Makes sense. What about neurological problems as CKD progresses?
As waste products, uremic toxins, build up, they affect the nervous system significantly. You can see uremic encephalopathy.
What does that look like?
Lethargy, difficulty concentrating, memory loss, confusion, eventually even seizures or coma in severe uremia.
And peripheral nerves?
Peripheral neuropathy is also common. Patients often complain of restless leg syndrome, that creepy, crawly feeling, especially at night, or a painful burning sensation in their feet.
Is there a classic physical sign related to motor function?
Yes, asterixis. This is often called a flapping tremor.
How do you check for it?
You ask the patient to hold their arms out and dorsiflex their wrists, bend them backwards, as if stopping traffic. In advanced uremia, they won't be able to maintain this posture. Their hands will intermittently flap downwards due to brief lapses in muscle tone.
So asterixis is a key sign of significant uremic toxicity.
It really drives home that kidney failure affects the entire body, right down to the nervous system. #3. Urinary tract obstruction and infections. CH33 and 35.
Okay, let's talk about things blocking the urinary tract, primarily kidney stones or renal calculi, most common cause of upper tract obstruction. We need to know about different stone types.
Definitely. The composition matters because it relates to the conditions under which they form.
Let's start with struvite stones. What's unique about them?
Struvite stones are made of magnesium ammonium phosphate. The key things to remember are they only form in alkaline urine, usually with a pH greater than 7.0.
Okay, alkaline urine. What else?
And their formation requires the presence of urease-producing bacteria, like Proteus or Klebsiella. These bacteria split urea into ammonia, which raises the urine pH and provides the ammonium component for the stone.
So infection stones, basically.
Often called infection stones, yes. And because they form in the presence of infection and can grow quite quickly, they can sometimes fill the entire renal pelvis and calyces, forming a massive staghorn calculus.
Wow. Okay, contrast that with uric acid stones.
Uric acid stones form under the opposite condition, acidic urine. Patients with gout or conditions causing high uric acid levels are at risk, especially if their urine is persistently acidic.
Is there anything special about seeing them on imaging?
Yes, unlike calcium-containing stones, which are the most common type overall, pure uric acid stones are typically radiolucent. They don't show up on a standard X-ray. You'd need CT or ultrasound to see them.
Good distinction. Okay, urinary tract infections, UTIs. What's the most common culprit for uncomplicated lower UTIs, like cystitis?
Overwhelmingly, it's Escherichia coli, E. coli, which normally lives in the gut.
And what's the body's main simple defense against bacteria getting into the bladder?
The washout phenomena. Just the simple mechanical flushing action of voiding urine helps wash bacteria out of the urethra before they can ascend and establish an infection in the bladder. Maintaining good hydration and frequent voiding is protective.
Makes sense. Lastly, let's touch on neurogenic bladder from Chapter 35. This is when nerve damage affects bladder function. Two main types based on the lesion level.
Right. It depends on whether the lesion is above or at the level of the sacral spinal cord segments that control micturition, urination.
What happens if the lesion is above the sacral reflex center, like in a spinal cord injury higher up?
If the lesion is above S2, S4, the connection between the brain and the bladder reflex is severed, but the local reflex arc remains intact. This leads to a spastic bladder, also called hyperreflexic or upper motor neuron bladder.
What does spastic mean in this context?
It means the bladder contracts reflexively and involuntarily whenever it gets slightly stretched. The person loses voluntary control, leading to frequency, urgency, urge incontinence, and a small bladder capacity. It's a failure to store urine properly.
Okay. Now, what if the lesion is at the sacral level, S2, S4, or damages the peripheral nerves, leaving the spinal cord to the bladder, like in diabetic neuropathy?
That damages the reflex arc itself. This results in a flaccid bladder, also called hypotonic or lower motor neuron bladder.
And flaccid means?
The bladder muscle loses its tone and becomes weak and unable to contract effectively. The person loses the sensation of fullness and the ability to initiate voiding voluntarily. The bladder becomes hugely distended with urine, leading to urinary retention and eventually overflow incontinence. Urine just dribbles out when the bladder pressure gets extremely high. It's a failure to empty.
Spastic, failure to store, lesion above sacral. Flaccid, failure to empty, lesion at below sacral.
Got it.
That's the core distinction. All right, we've filtered through the kidneys, ready to move to the gut. Absolutely. Let's tackle gastrointestinal, hepatobiliary, and pancreas pathophysiology from chapters 37 and 38. Okay, quick check-in for potential renal exam questions. How about this? A patient presents with AKI. Labs show a BUN of 44, creatinine of 2.0, so a 22.1 ratio, and a FeNA of 0.5%. What's the most likely type of AKI, and what does that BUN-CR ratio tell you about compensation?
Classic prerenal picture. The high ratio indicates disproportionate BUN reabsorption due to slow tubular flow, showing the kidney is trying to compensate for low perfusion. The low FeNA confirms the tubules are avidly reabsorbing sodium.
Good. How about CKD symptoms? Which common clinical sign often seen in dialysis patients involves creeping, prickling, itching sensation, worse at rest? And what's the likely cause in CKD?
That sounds like restless leg syndrome, often related to the peripheral neuropathy seen in uremia, possibly iron deficiency too.
Okay, kidney stones. A patient has a large staghorn calculus filling the renal pelvis. What stone composition is most likely, and what specific urine characteristic is required for it to form?
Staghorn usually points to struvite, magnesium ammonium phosphate. And the required characteristic is alkaline urine, pH 7.0, plus urese-producing bacteria.
Perfect. And finally, that crucial cascade. Outline the step-by-step process, starting with impaired phosphate excretion that leads to renal osteodystrophy in CKD.
That tests the whole MBD pathway. High phosphate metalinda, low calcium dialysable, low active D, high PTH bone resorption disease. Need every step. Okay, on to the GI tract.
Let's do it.
All right, starting at the top. GERD, gastroesophageal reflux disease. Fundamentally, it's the persistent backflow of acidic stomach contents into the esophagus.
Usually because the lower esophageal sphincter, LES, isn't working properly. And the classic symptoms.
Heartburn, pyrosis, and regurgitation are the big ones. Often worse after meals or when bending over or lying flat positions that make reflux easier.
What are the potential long-term complications if GERD isn't managed?
Chronic acid exposure can damage the esophageal lining, causing inflammation, esophagitis, erosions, or even strictures, narrowing. The most serious concern is bare esophagus. It's a metaplastic change, where the normal squamous lining of the lower esophagus gets replaced by a columnar lining, similar to the intestine.
And why is that bad?
Because bare esophagus is a known precursor lesion, significantly increasing the risk of developing esophageal adenocarcinoma, a serious cancer.
Okay. Is there a link between GERD and respiratory issues too?
Yes, definitely. GERD is a common trigger or exacerbator of asthma. It can also cause chronic cough or laryngitis.
Ow.
Two main theories. One is direct microaspiration of tiny amounts of stomach acid into the airways, causing irritation. The other is a reflex mechanism. Acid irritating the lower esophagus might trigger a vagal nerve reflex that leads to bronchospasm.
Interesting connection. Now, inside the stomach itself, what protects it from its own harsh acid and pepsin?
The gastric mucosal barrier. It's a multi-layered defense system, including a thick mucus layer, bicarbonate secretion to neutralize acid near the surface, tight junctions between cells, and good blood flow.
And what chemical messenger is really key for maintaining that barrier?
Prostaglandin E2, PGE2, is crucial. It plays a major defensive role.
Ow.
PGE2 does two main things. It inhibits acid secretion by the parietal cells, and it stimulates the production of protective mucus and bicarbonate by the surface epithelial cells. It's like the guardian of the gastric lining.
So things that interfere with prostaglandins are bad for the stomach lining?
Exactly. Which brings us to the major causes of damage and ulceration, aspirin and NSAIDs.
Because they block prostaglandin synthesis.
Right. By inhibiting the COX enzymes, they shut down the production of those protective prostaglandins like PGE2, leaving the mucosa vulnerable to acid attack. That's why NSAIDs are a major cause of peptic ulcers.
And the other huge culprit for chronic gastritis and ulcers.
Helicobacter pylori, H. pylori infection. It's the most common cause of chronic gastritis worldwide.
This is a fascinating bug. How does this gram-negative rod manage to survive in the extreme acidity of the stomach?
It has a remarkable trick up its sleeve.
Aha.
It produces large amounts of an enzyme called urease.
Urease, what does that do?
Urease breaks down urea, which is normally present in gastric secretions, into ammonia and carbon dioxide. Ammonia is alkaline.
Ah, so it creates its own little cloud of neutral pH around itself.
Precisely. The ammonia buffers the stomach acid right in the bacteria's immediate vicinity, allowing it to colonize the protective mucus layer overlying the epithelial cells where the pH is less harsh. It's an incredible adaptation.
And chronic infection is linked to.
Increased risk of peptic ulcer disease, both gastric and duodenal, gastric adenocarcinoma, and a type of lymphoma called multi-lymphoma.
Okay, one more type of ulcer to differentiate. The stress ulcers seen in critically ill patients. Two specific types.
Yes, curling ulcers and Cushing ulcers. They occur in different clinical settings and likely have different mechanisms.
Curling ulcers associated with?
Severe burns.
Right.
Large surface area burns. The leading theory is that the massive fluid shifts and stress response associated with major burns cause widespread ischemia, lack of blood flow, to the gastric mucosa, leading to breakdown and ulceration.
So curling burns, ischemia. What about Cushing ulcer?
Cushing ulcers are associated with severe head injuries or increased intracranial pressure.
Different cause.
Believed to be, yes. The thinking is that the brain injury leads to overstimulation of the vagus nerve.
And the vagus nerve stimulates.
Gastric acid secretion. So Cushing ulcers are thought to result from hypersecretion of gastric acid, driven by that central nervous system injury.
Right.
Curling ischemia. Cushing is acid hypersecretion. #2. Inflammatory bowel disease. IBD comparison.
Okay, this is a classic comparison that trips students up. Crohn's disease versus ulcerative colitis, UC. They're both inflammatory bowel diseases, but they're distinct. Let's nail down the key differences. Location first.
Big difference here. Ulcerative colitis is limited only to the colon and rectum. It almost always starts in the rectum and spreads proximally in a continuous fashion.
And Crohn's?
Crohn's disease can affect any part of the GI tract, from the mouth to the anus. However, it most commonly affects the terminal ileum and the colon, often in a patchy distribution.
Okay, location. UC colon rectum only, continuous. Crohn's anywhere, often ileum colon, patchy. Next, depth of inflammation. How deep into the wall does it go?
Also crucial, UC inflammation is generally limited to the mucosa and submucosa, the inner layers only.
And Crohn's?
Crohn's is typically transmural, meaning the inflammation extends through all layers of the bowel wall, from mucosa to serosa. It often starts in the submucosa but progresses deeper.
UC superficial layers, Crohn's full thickness transmural. What about the pattern of the lesions?
We touched on this. UC lesions are confluent and continuous. The inflammation spreads like a carpet without breaks, starting distally. Crohn's is famous for its skipping lesions. You have areas of inflamed bowel separated by segments of completely normal appearing bowel.
Yeah.
Patchy. Cobblestone appearance is also characteristic due to submucosal edema and linear ulcerations.
UC continuous carpet, Crohn's skipping stones, cobblestones. How about surgery? Is colectomy curative?
For UC, because it's confined to the colon and rectum, removing the entire colon and rectum, total proctocolectomy, is curative for the disease itself, though patients may have other issues like bursitis.
But for Crohn's?
Since Crohn's can occur elsewhere in the GI tract, surgery like a colectomy is not curative. It's often needed to manage complications like strictures or fistulas, but the disease can recur in other locations.
Not curative. Finally, the main symptom, especially regarding stool.
Because UC primarily affects the colonic mucosa, the hallmark symptom is bloody diarrhea. Rectal bleeding is very common.
Crohn's.
Diarrhea is common in Crohn's too, but it's often less bloody than in UC. Abdominal pain, often ROQ with ileal involvement, weight loss, and complications like fistulas or abscesses are more characteristic of Crohn's, partly due to that transmural inflammation.
Okay, that's a solid comparison table in our heads. Location, layer, lesion pattern, surgical cure, stool, got it, #3, hepatobiliary, and pancreas disorders, CJH38. Moving to the liver, gallbladder, pancreas. Let's start with jaundice, the yellowing of skin, and sclera. It happens when bilirubin levels get too high, usually over 2 to 2.5 milli-GDL. How do we classify jaundice based on the cause?
We think about where the problem is relative to the liver's processing of bilirubin, prehepatic, intrahepatic, or posthepatic.
Prehepatic jaundice.
This means the problem is before the liver. It's caused by an excessive breakdown of red blood cells, hemolysis. Think hemolytic anemia, sickle cell crisis, transfusion reactions. The liver's working fine, but it's simply overwhelmed by the sheer amount of bilirubin being produced from all the broken down serum.
So too much bilirubin arriving at the liver. What about intrahepatic jaundice?
Here, the problem is within the liver itself. The liver cells, hepatocytes, are damaged or dysfunctional and can't properly take up, conjugate, process, or excrete bilirubin.
What causes that?
Things like viral hepatitis, Hep A, B, C, alcoholic liver disease, cirrhosis, drug-induced liver injury. The liver cells themselves are sick.
Makes sense. And posthepatic jaundice?
This means the problem is after the liver, involving an obstruction of bile flow out of the liver and gallbladder, through the bile ducts and into the intestine. It's also called cholestatic jaundice.
What causes the blockage?
Most commonly gallstones stuck in the common bile duct. Also tumors, like pancreatic cancer pressing on the duct, biliary strictures, cholangitis. Something is physically blocking the drainage of bile.
How do the signs in labs differ in posthepatic obstructive jaundice?
Because the liver can still conjugate bilirubin, but it can't get out, you see a buildup primarily of conjugated direct bilirubin in the blood. Liver enzymes like alkaline phosphatase, ALP and GGT, are often markedly elevated because they line the bile ducts.
And the stool and urine?
Since bile, containing conjugated bilirubin, can't reach the intestine to be broken down into urobilinogen, which gives stool its brown color, the stools become pale or clay-colored. And the excess conjugated bilirubin spills over into the bloodstream and gets filtered by the kidneys, making the urine very dark, like tea or cola.
Clay stools, dark urine, anything else?
Yes, a very important symptom. Pruritus, or intense itching. This is caused by the accumulation of bile acids in the skin. Often, the itching starts before the jaundice is even visible. So itching plus high conjugated bilirubin plus high alk phos strongly suggests posthepatic obstruction.
Pruritus as an early warning sign. Okay. Quick hit on viral hepatitis transmission routes. HAV.
Hepatitis A virus, HAV. Fecal-oral route. Think contaminated food or water, poor sanitation, outbreaks in daycare centers, or from infected food handlers. Usually causes an acute self-limited illness. Doesn't become chronic.
HDV.
Hepatitis B virus, HBV. Blood and body fluids. Transmitted via infected blood, needles, sexual contact, or from mother to baby during birth. Much more serious can cause acute and chronic hepatitis, cirrhosis, and liver cancer. There's a carrier state, vaccine preventable. Hepatitis C virus, HCV. Primarily bloodborne, most commonly through shared needles among IV drug users, also sexual transmission, but less efficient than HBV. High rate of chronic infection, leading cause of cirrhosis and liver transplants. Now often curable with antiviral drugs.
And HGV.
Hepatitis E virus,
Yeah.
HEV. Also fecal-oral, similar transmission to HEV, often waterborne outbreaks in developing countries. Usually acute and self-limited like HEV, but it can cause severe fulminant hepatitis in pregnant women and can become chronic in immunocompromised individuals.
Got the transmission routes. Now, a major complication of advanced liver disease, portal hypertension. What is it?
It's high blood pressure, specifically within the portal venous system, the network of veins that brings blood from the intestine, spleen, and pancreas to the liver. Cirrhosis is the most common cause in Western countries. The scarring obstructs blood flow through the liver.
So blood backs up behind the obstructed liver. What are the major consequences of this backup and high pressure?
3 big ones. First, ascites. The increased hydrostatic pressure in the capillaries of the gut and peritoneum forces fluid out into the abdominal cavity. Low albumin synthesis by the failing liver also contributes.
Fluid in the belly.
Second, splenomegaly, enlarged spleen, and hypersplenism. Blood backs up into the spleen, causing it to enlarge and become overactive, potentially trapping and destroying more blood cells, platelets, WBCs.
Third,
Formation of portosystemic shunts or varices. The high pressure forces blood to find alternative routes back to the systemic circulation, bypassing the liver through smaller collateral veins.
where do these collateral veins form?
Most dangerously, in the lower esophagus, esophageal varices, and stomach. Also around the rectum, hemorrhoids, and abdominal wall, caput medusae.
And why are esophageal varices so dangerous?
Because these veins are thin-walled and under high pressure. They can easily rupture and cause massive, life-threatening gastrointestinal bleeding, a major emergency in patients with cirrhosis.
Okay. Finally, acute pancreatitis. Inflammation of the pancreas. What's the underlying mechanism?
It's essentially autodigestion. Pancreatic enzymes, which are normally secreted in an inactive form and only activated in the duodenum to digest food, somehow get activated prematurely within the pancreas itself. These activated enzymes then start digesting the pancreatic tissue, causing inflammation, edema, hemorrhage, and necrosis.
What triggers this inappropriate activation? What are the main causes?
The two most common causes are gallstones and chronic alcohol abuse.
How do gallstones cause it?
A gallstone can pass out of the gallbladder and get lodged temporarily in the common bile duct, right at the ampulla of Werther, where the pancreatic duct also drains. This blockage can cause reflux of bile into the pancreatic duct or obstruct pancreatic outflow, triggering enzyme activation.
And alcohol.
The mechanism with alcohol is more complex and not fully understood, but it likely involves direct toxic effects on pancreatic acinar cells, changes in pancreatic secretions, and possibly spasm of the sphincter of Oddi.
What's the cardinal symptom of acute pancreatitis?
Severe abdominal pain. Typically, it's acute onset, steady, boring pain in the epigastric or periumbilical region, and classically it radiates straight through to the back. Often worse when lying flat, better when leaning forward. Nausea and vomiting are also very common.
How do we gauge the severity? What's a major concern?
A key indicator of severity is the degree of systemic inflammatory response and fluid loss. In severe pancreatitis, there can be a massive leakage of fluid from the circulation into the retroperitoneal space and around the pancreas, third spacing,
Leading to?
potentially profound hypovolemia, shock, acute respiratory distress syndrome, ARDS, and multi-organ failure. Managing fluid resuscitation aggressively is critical in severe acute pancreatitis.
Okay, that covers the GI hepatobiliary pancreas section well. Let's pause for questions before our last system.
All right, GI questions. How about
Go.
explain the mechanism by which H. pylori survives in the stomach's acidic environment?
Tests the urease enzyme producing ammonia to buffer the acid. That's a good mechanism question.
Or diagnosis. A patient presents with jaundice. They mention intense itching started a week before the yellowing. Labs show high conjugated bilirubin and high alkaline phosphatase. What classification of jaundice is most likely?
The itching pruritus preceding jaundice, plus the high conjugated bili and OCPHOS, points strongly to posthepatic cholestatic obstructive jaundice.
Exactly. Comparison. Contrast the underlying pathology and likely causes of a curling ulcer versus a Cushing ulcer.
Curling burns a ischemia. Cushing head injury, vagal stimulation, expirin, acid hypersecretion. Gotta know the difference.
And one more mechanism. Explain why portal hypertension contributes to the development of ascites.
Need to mention the increased hydrostatic pressure in peritoneal capillaries forcing fluid out, maybe also the contribution of low albumin in liver failure, reducing oncotic pressure. Okay, final section, endocrine.
Let's wrap it up with endocrine and a bit of nutrition, chapters 41 and 39. When you're faced with endocrine labs, the first step is always classifying the disorder based on where the problem lies in the hypothalamic pituitary target gland axis. This is fundamental.
Okay, so primary disorder means?
The problem originates in the target endocrine gland itself. The thyroid, the adrenal cortex, the ovary, etc. The gland is failing or maybe overproducing on its own.
Can you give an example using the thyroid?
Sure. Primary hypothyroidism. The thyroid gland itself is failing, maybe due to Hashimoto's. It can't produce enough T3 and T4. The pituitary gland senses this lack of thyroid hormone and tries to stimulate the thyroid harder by pumping out lots of thyroid-stimulating hormone, TSH.
So in primary hypothyroidism, you see low T3, T4, but high TSH. The pituitary is yelling at a failing thyroid.
Exactly. That pattern is primary hypothyroidism.
Okay. What about a secondary disorder?
The problem originates in the pituitary gland. The pituitary fails to secrete the stimulating hormone properly, like TSH, ACTH, LHFSH. The target gland is actually healthy, but it's not getting the signal to work.
So in secondary hypothyroidism,
The pituitary isn't making enough TSH, so the thyroid doesn't get stimulated and produces low T3, T4. In this case, you'd see low T3, T4 and also low TSH.
both are low because the pituitary signal is missing. And tertiary disorder.
The problem originates in the hypothalamus. The hypothalamus isn't releasing hormones like TRH, CRH properly, which then affects the pituitary, which then affects the target gland. You'd see low levels all the way down the chain.
Yeah.
Primary, secondary, tertiary, know the source.
Got it. Let's focus on hypothyroidism. Acquired hypothyroidism, what's the most common cause in adults?
Hashimoto thyroiditis. It's an autoimmune disease where the body's own immune system attacks and destroys the thyroid gland tissue over time.
And the symptoms reflect a slowed metabolism.
Yes, decreased metabolic rate leads to fatigue, weight gain, cold intolerance, constipation, slowed thinking, and myxedema.
Myxedema, what's that exactly?
It's a characteristic non-pitting edema, often seen in the face, puffy eyes, hands, and feet. It's caused by the accumulation of hydrophilic mucopolysaccharide substances in the dermis and other connective tissues, pulling water in. distinct from regular edema.
Okay. What about congenital hypothyroidism? Why is this so critical to detect early?
Because thyroid hormone is absolutely essential for normal brain development and physical growth, especially during the first few months and years of life.
So if a baby is born without a functioning thyroid or doesn't produce enough T3, T4, and it's not treated promptly,
It leads to severe, irreversible intellectual disability and stunted physical growth. This condition was historically called cretinism. Newborn screening for congenital hypothyroidism is standard practice in developed countries precisely to prevent this outcome by starting thyroid hormone replacement immediately. #2. Adrenal disorders. Insufficiency versus excess.
moving to the adrenal glands. Let's compare insufficiency versus excess. Start with primary adrenal insufficiency, also known as Addison disease. What's being destroyed here?
In Addison disease, there's destruction of all three layers of the adrenal cortex. The zona glomerulosa makes aldosterone, fasciculata makes cortisol, and reticularis makes androgens. So you get a deficiency of mineralocorticoids, aldosterone, glucocorticoids, cortisol, and adrenal androgens.
What's the most common cause of this destruction?
Autoimmune destruction is the most common cause in developed countries. The immune system attacks the adrenal cortex. Worldwide, TB used to be a major cause.
What are the key signs that help distinguish primary insufficiency, Addison's, from secondary pituitary failure? These relate to the feedback loop, right?
Exactly. In primary failure, the adrenals aren't making cortisol. The pituitary senses this and cranks out huge amounts of ACTH, adrenocorticotropic hormone, trying to stimulate the failing adrenals.
And high ACTH causes.
Hyperpigmentation. ACTH is derived from a larger precursor molecule, POMC, that also contains a melanocyte-stimulating hormone, MSH fragments. Very high ACTH levels lead to increased MSH activity, causing darkening of the skin, especially in sun-exposed areas, skin creases like palms, pressure points, elbows, knees, and mucous membranes like inside the mouth. This occurs in over 90% of Addison's cases.
So hyperpigmentation strongly suggests primary adrenal failure due to high ACTH. What about electrolytes?
The lack of aldosterone is critical here. Aldosterone normally tells the kidneys to save sodium and excrete potassium. Without it, you waste sodium and retain potassium. So hyperkalemia, hypotassium, is very common, seen in about 60–65% of patients. Hyponatremia, low sodium, and volume depletion also occur.
Okay, high ACTH hyperpigmentation, no aldosterone hyperkalemia, key features of Addison's. Now, flip side, glucocorticoid excess, generally called Cushing's syndrome.
Cushing's syndrome refers to the signs and symptoms resulting from prolonged exposure to excess cortisol, regardless of the cause.
So what are the potential causes? How do we differentiate them?
The most common cause overall is actually exogenous, taking high doses of glucocorticoid medications like prednisone for other conditions, but focusing on endogenous causes.
Okay.
If the excess cortisol is caused by an ACTH-secreting tumor within the pituitary gland, that specific condition is called Cushing disease. The pituitary is overproducing ACTH, which overstimulates otherwise normal adrenal glands to make too much cortisol.
So Cushing disease, a pituitary tumor source, what if the ACTH is coming from somewhere else?
That's called ectopic Cushing syndrome. Here, a non-pituitary tumor somewhere else in the body is inappropriately secreting ACTH.
Like what kind of tumor?
Small cell lung cancer is a classic example. These tumors can sometimes produce and release biologically active ACTH, driving the adrenals to pump out cortisol. So you have high ACTH and high cortisol, but the source isn't the pituitary.
And you could also have a primary adrenal tumor just making cortisol on its own, right?
Yes, that would be an ACTH-independent cause of Cushing syndrome. An adrenal adenoma or a carcinoma making cortisol autonomously. In that case, the high cortisol would suppress pituitary ACTH, so you'd see high cortisol but low ACTH. Differentiating the cause is crucial for treatment. #T3. Diabetes mellitus, DM, and glucose control.
Right. Diabetes mellitus. Type 1 versus type 2. Quick distinction.
Type 1 DM, an absolute deficiency of insulin, is usually caused by autoimmune destruction of the pancreatic beta cells, the cells that make insulin. Patients require insulin injections for survival.
Type 2 DM, much more common. It involves two core defects. Insulin resistance. The body's tissues, especially muscle fat and liver, don't respond properly to insulin, combined with a relative lack of insulin secretion. The beta cells can't keep up with the increased demand caused by resistance, and their function often declines over time.
Okay. Now, blood glucose isn't just controlled by insulin. There are hormones that do the opposite, raise blood glucose. The counter-regulatory hormones, how are they? Four main ones. Glucagon from pancreatic alpha cells, epinephrine, adrenaline from the adrenal medulla, growth hormone, GH, from the pituitary, and glucocorticoids, like cortisol from the adrenal cortex.
What's their main job?
They protect against hypoglycemia, low blood sugar. They ensure the body has enough glucose, especially during fasting, exercise, or stress, by stimulating glucose production, gluconeogenesis, and release glycogenolysis from the liver, and by promoting fat breakdown for alternative fuel.
Which one acts really fast in acute stress or low sugar?
Epinephrine is the rapid responder. It quickly stimulates glycogen breakdown in the liver, inhibits insulin release from any remaining beta cells, and increases fatty acid availability from fat stores. It's key in the immediate response to hypoglycemia or stress.
Glucagon also acts quickly on the liver. Cortisol and GH have slower, more sustained effects.
Generally, yes. Cortisol especially plays a role in more prolonged stress, promoting gluconeogenesis and contributing to insulin resistance. Tag 4. Acute complications of diabetes. Mechanism focus.
Let's focus on the acute dangerous complications, starting with diabetic ketoacidosis, DKA. This is most common in type 1, right? Due to that absolute lack of insulin.
Correct. DKA is defined by a triad of major problems: hyperglycemia, very high blood sugar, ketosis, buildup of ketone bodies, and metabolic acidosis due to the ketones.
Let's break down the mechanism. Why do ketones build up so dramatically?
It's driven by that absolute insulin deficiency combined with high levels of counter-regulatory hormones, especially glucagon and epinephrine. Lack of insulin means glucose can't get into cells easily for energy. Plus, lack of insulin suppressive effect allows unrestrained release of fatty acids from adipose tissue, lipolysis.
So tons of fat breaks down.
Yes. These fatty acids flood the liver. The hormonal milieu, low insulin, high glucagon, strongly promotes the conversion of these fatty acids into ketone bodies, acetoacetate and beta-hydroxybutyrate, via accelerated beta oxidation and ketogenesis.
And the liver just pumps them out way faster than the body can use them.
Exactly. The production rate vastly exceeds the peripheral utilization, so ketones accumulate rapidly in the blood. Since they are acidic, this leads directly to metabolic acidosis.
Okay, that covers the K and A of DKA. The D is hyperglycemia. Why does that happen, and what's the consequence?
Hyperglycemia occurs because glucose can't enter cells without insulin, and the counter-regulatory hormones stimulate massive glucose production by the liver. When blood glucose gets extremely high, often 250 milli-ddl, sometimes much higher, it exceeds the kidney's ability to reabsorb glucose from the filtrate.
So glucose spills into the urine.
Yes, causing an osmotic diuresis. The high glucose concentration in the renal tubules pulls large amounts of water out with it, leading to severe dehydration, electrolyte loss, and increased serum osmolality.
Speaking of electrolytes, there's that tricky thing with sodium acetohyponatremia. What's going on there?
The extreme hyperglycemia makes the extracellular fluid very hyperosmolar, concentrated. This high osmolality pulls water out of the body's cells and into the extracellular space by osmosis.
Diluting the sodium that's already there?
Exactly.
Yeah.
It dilutes the existing extracellular sodium, making the measured serum sodium concentration appear low, even though the patient is actually severely dehydrated and may have lost total body sodium. It's a dilution effect, hence pseudohyponatremia. You have to correct the measured sodium for the high glucose level to estimate the true sodium status.
Critical point for treatment. Okay, one other acute phenomenon, the Somogyi effect. What is that?
The Somogyi effect is essentially rebound hyperglycemia following an episode of hypoglycemia, often insulin-induced.
How does it happen? Like maybe too much insulin bedtime?
Exactly. A common scenario is a patient takes their evening or bedtime insulin, it peaks overnight, causing their blood sugar to drop too low. Hypoglycemia, maybe while they're asleep and unaware.
Body panics.
The body senses the hypoglycemia and mounts a strong counter-regulatory hormone response, releases glucagon, epinephrine, cortisol, growth hormone.
And these hormones
Drive the blood sugar back up by stimulating glucose production. But the response is often excessive, leading to significant hyperglycemia by the time the patient checks their sugar in the morning. They wake up high, not realizing they were low overnight. It can also make them temporarily more insulin resistant.
So morning hyperglycemia might actually be caused by too much insulin the night before. Tricky to manage.
Very tricky. Differentiating it from the dawn phenomena, a natural rise in glucose in the early morning due to GH secretion, often requires overnight glucose monitoring. Tag 5. Nutritional SATES, CH39.
Let's wrap up with a couple of key concepts from nutrition, Chapter 39. First, basal metabolic rate, BMR, or resting energy expenditure, REE. What is that?
It's the minimum amount of energy the body needs to expend just to stay alive at rest in a neutral temperature environment after an overnight fast. It covers basic functions like breathing, heartbeat, brain activity, maintaining body temperature.
And it accounts for a big chunk of our daily energy needs.
Yes, typically about 50 to 70% of total daily energy expenditure for most people.
Okay. Now, obesity classification. We often talk about fat distribution being important. Upper body or central obesity, the apple shape. Why is this considered higher risk?
Central obesity, defined by a high waist-to-hip ratio, usually 1.0 for men and 0.8 for women, or just a large waist circumference, is strongly associated with increased metabolic risk. Things like insulin resistance, type 2 diabetes, high triglycerides, low HDL, hypertension.
Why is that visceral fat around the organs so bad?
Because visceral fat is metabolically very active. It releases inflammatory cytokines, adipokines, and free fatty acids directly into the portal circulation, which goes straight to the liver.
And this affects the liver how?
This direct delivery of fatty acids and inflammatory signals to the liver contributes significantly to hepatic insulin resistance and the development of non-alcoholic fatty liver disease, NAFLD. Abdominal fat isn't just passive storage.
Good point. Finally, differentiating the two severe forms of protein energy malnutrition, especially in children. Kwashiorkor versus marasmus.
Key differences here. Kwashiorkor is primarily a deficiency of protein, even if calorie intake might be relatively adequate, often seen when a child is weaned from breast milk onto a high-starch, low-protein diet.
What are the classic signs of kwashiorkor?
The most striking feature is generalized edema, especially swelling of the belly, ascites, legs, and face. This is largely due to severe hypoalbuminemia. Lack of protein means low albumin in the blood, reducing oncotic pressure, so fluid leaks out into tissues.
Do they look wasted?
Not necessarily all over. A key feature is that subcutaneous fat is often preserved. They might look puffy or plump due to the edema, but they lack muscle protein. Other signs include skin changes, flaky paint dermatosis, hair discoloration flag sign, apathy, and an enlarged fatty liver.
Okay, edema, preserved fat, skin hair changes. Now marasmus.
Marasmus is a deficiency of both protein and total calories. It's essentially starvation.
So the appearance is very different.
Dramatically different. Children with marasmus exhibit severe wasting of muscle mass and loss of subcutaneous fat all over the body. They look emaciated, like skin and bones, often with wrinkled skin because the fat underneath is gone. There's typically no edema. They suffer severe growth failure. Kwashiorkor, protein deficit with edema. Marasmus equal total energy deficit with severe wasting.
Crucial distinction. Okay, that covers our deep dive into the endocrine and nutritional aspects.
Let's do some final check questions. How about compare primary adrenal insufficiency, Addison's, with secondary adrenal insufficiency. Specifically, which one typically has hyperpigmentation and why?
Tests the ACTH feedback loop. Primary Addison's has high ACTH, leading to hyperpigmentation. Secondary has low ACTH, so no hyperpigmentation. Need to explain the ACTH level difference?
Good. Acute pathophysiology. In DKA, the liver produces lots of ketones. Explain the source of the substrate, the fuel for this accelerated ketogenesis.
The substrate is fatty acids released from adipose tissue due to lack of insulin suppressive effect and high counter-regulatory hormones. The liver converts these fatty acids to ketones.
Exactly. Clinical comparison. A malnourished child has generalized edema, a flag sign in their hair, but seems to have normal subcutaneous fat stores. Which form of protein energy malnutrition is most likely?
The edema and preserved fat point strongly to kwashiorkor, protein deficiency. Marasmus would have wasting and no edema.
Perfect. And one last endocrine classification. A patient has fatigue, weight gain, very low T3, T4, but their TSH level is extremely high. Classify this disorder, primary, secondary, or tertiary, and explain the high TSH.
Low T3, T4 with high TSH is the classic pattern for primary hypothyroidism. The pituitary is producing high TSH because it senses the low thyroid hormone levels coming from the failing thyroid gland itself. Okay, I think we've covered the core high-yield points across all four systems. #G, outro.
We certainly have. We've hit a lot of crucial mechanisms today, from the respiratory system's mucociliary defense and the vital roles of SPB and SPC in surfactant, to the distinct stages of pneumococcal pneumonia. Then in renal, we nail down the diagnostic clues for pre-renal AKI, that BU-NCR ratio, the low FINA, and trace the entire CKD-MBD cascade, including that often forgotten vitamin D activation step.
Yeah, and for GI, the clear lines drawn between Crohn's and UC based on layer involvement and pattern, the difference between curling and Cushing ulcers, and how H. pylori cleverly uses urease.
And finally, in endocrine, distinguishing primary versus other adrenal insufficiencies using ACTH and hyperpigmentation, understanding the fuel source for DKA ketones, and separating kwashiorkor from marasmus.
It really comes down to mastering these core mechanisms, the sequences, the comparisons. That pattern recognition is key for doing well on exams and, honestly, for understanding clinical practice.
Absolutely. Use this deep dive as a framework. Go back, solidify these pathways in your mind.
And maybe a final thought to leave you with. As you study these different systems, notice the common thread of inflammation and Alveolar homeostasis.
That's a great point. Think about it. Chronic inflammation destroying lung tissue in COPD, eroding the GI wall in IDD or PUD, the systemic inflammatory response in severe pancreatitis or sepsis leading to AKI, the autoimmune attacks in Hashimoto's or Addison's.
It's all connected by these fundamental processes of injury, inflammation, and the body's attempt, sometimes successful, sometimes failing to restore balance.
Understanding how inflammation works, how stress responses impact different organs, and how homeostasis gets disrupted, that's really at the heart of pathophysiology. So keep digging into those connections.
Definitely. Use this deep dive to sharpen your focus on those high-yield mechanisms. Good luck with your studies, and thanks for joining us.
Yes, keep working hard. You've got this. Until next time.